I think I have her number, ma'am. Okay. Okay, ma'am. Sure, ma'am. Yes, ma'am. Okay, ma'am. The previous one, camera isn't that speaker on the namaka isn't a speaker. Headphone on headphone to mic.
Good afternoon, friends. It is Friday afternoon, going to be 3 o'clock. The next talk in our series, The Forefront of Future Frontiers. This is a medical webinar series which is organized by the Scientific Society of Aarupadai Veedu Medical College, which is a constituent college of Vinayaka Mission Research Foundation, a deemed to be university. Our purpose of conducting these medical webinars, we are now in series 2, is to bring in novel therapeutics and issues in the horizons, currently in the horizons of medical healthcare and practice to mainstream. So that is the purpose of this webinar series. And for series 2, we have chosen the topic of the COVID pandemic. We explored the role of evidence-based medicine and its challenges in its practice. We started with that. Then we talked about humanity's response to COVID pandemic. Professor K. Sethuraman sir did that. And on the third talk, we spoke about how COVID has impacted education, especially the clinical skills education, and how simulation is going to be the answer, or which is turning out to be the answer for that. So those are the 3 topics we have done for this series 2. And now we have with us today Professor George Chandy, and he is going to talk to us about the epidemiology of COVID, how to learn to live with COVID. I think that is what sir phrased that talk as, learning to live with COVID. And let us explore the epidemiology and see what actions we have been doing in the context of scientific reliability and validity. So that is going to be today's session. We have with us Dr. George Chandy. Before I pass on the privileges to him, I would request our Dean, Professor P.F. Kotur, to welcome the speaker and the audience. Sir, over to you, sir, Dr. Kotur.
Yeah, very good afternoon to Professor Chandy and all for this webinar series. This is the 10th in the line, second series. And as the head of the institution, I take this opportunity of welcoming our esteemed speaker, Dr. Chandy. We all know him, liver transplant surgeon of international repute, B.C. Roy Awardi, who was the former director of prestigious CMC Vellore. He will be spending his precious time with us all. And just a few words about this scientific society. This AVMC is a constituent unit of the Vinayaka Mission Research Foundation, a deemed to be university headquarters at Salem. And this Aarupadai Medical College here at Puducherry is a constituent unit of it. We have a very vibrant scientific society, and we created this platform when this COVID-19 struck the mankind, the greatest disaster, greatest setback to the mankind, stuck. Then we wanted to keep all our scholarly acts going, and including the teaching, learning, the professional developments, etc., has to happen to all the professionals. In addition to helping them to grow, and it will also keep us going in the sense when we don't have any, our all activities are disrupted, when you are confined to some 4 walls, then you will certainly have manifest in very different ways. This is how this platform, at the instance of our Honorable Chancellor, Dr. Ganeshan, has been created. We really thank on of you all, but for his thoughts, this would not have been created. And 1 or 2 thoughts about this COVID pandemic. You all know that this COVID pandemic has been causing a lot of great pain to all of us. And more painful than that is, it's a very powerful blow, is the way it is being handled, or rather mishandled. I use the word, I dare to use the word, across the globe. And this confining our thoughts to our country, we didn't have the national disaster plan. One came into existence in 2016, but that was not in place. So in the absence of any structured disaster management plan, whatever you do will be categorized ad hoc. So ad hoc measures will yield very unfaithful or unexpectable, unpredictable outcomes. Now, if you just think over and recently what has been happening around us across the globe, see, there has been so much of confusion because of the ad hocism. There has been so many things, for example, they have started with the chloroquine therapy, give or not to give, so many countries, so many confusion, India liberating its export, those kind of things. ICMR puts out a study, then says that it is quite useful, these kind of a thing. This is something clear. Even other things, related to the diagnostics tests, manufacturing of the kits, and even the most recent one you must have read yesterday, the beautiful article by Dr. Kalantri from Sevagram about the viral, that is Favipiravir, So that has been given, DCGI, Drug Controller General of India, has given an accelerated approval for its use for mild and moderate patients, And there nothing is available on the website of the DCGI. What was the basis for this drug to be approved? These kind of things have been happening. Even, the simple face mask or simple PPE, there has been no structured guideline. And the Thiruvalla, here in Tamil Nadu, is the one which is supplying manufacturing. Quite a lot of many people have invested so much, and now halfway through, some guidelines they are trying to put in. So such is the confusion, and it has caused so much of confusion, chaos rather. I should be able to say that it's quite difficult for even all the learned people, and in the absence of these definite things, we are getting exposed. Second wave has started. Even our hospital today will be seeing 100 patients, 2 patients. So these are some of the things we have to deal with. And one thing is, at this point, I like to just conclude what I want to say. Time like this demands strong mind, great heart, true faith, and ready hands. This is one I think is appropriate to think of that. With these few words, I take this opportunity of welcoming Professor George Chandy. This COVID. Over to you, sir.
Okay. Thank you, Dr. Kotur. We move on. Let me introduce Professor Chandy to the audience. Many of us know him very well, but it is for the benefit of others. Professor George Chandy is the Medical Director and CEO of the Believers Church Medical College Hospital in Thiruvalla. He is also the former Director and Head of the Department of Gastroenterology and Hepatology in CMC Vellore. He has received the BC Royd Award for Excellence in Healthcare Leadership by President of India in the year 2018. And he has been a pioneer in the field of hepatology and liver transplant. In this connection, he has headed the ICMR Advanced Center for Liver Diseases in the year 2007. And then he initiated this hepatitis B awareness and safety initiatives. See, one of the rarest of its kind, which made hepatitis B vaccine accessible to the entire districts of Vellore. And this is one of the things which has made Vellore into hepatitis-free zone. And not only that, Dr. Chandy is also quite interested in various other topics. So if you actually put YouTube of Dr. Chandy, you would get to see a lot of interesting talks on the role of cost effectiveness in healthcare, how we need to network among ourselves to ensure that we share knowledge and expertise. And he's a great supporter and avid supporter of the organ donation programs across the country. And his talks, especially on ethics and professionalism in practice and service to humanity, especially I think it comes in that Malayalam channel, and how we should respect and recognize the role of allied health professionals in our practice. So these are some of those areas, apart from his interest in the current role of healthcare in the country and how it needs to be. So this is a short introduction for Dr. Chandy. We will move over to Dr. Chandy. We will listen to Sir talk an exploration of epidemiology of COVID, learning to live with it. Over to you, Dr. Chandy.
Dr. Kotur, Dr. Mahalakshmi, thank you very much for the welcome, for the introduction, and for the privilege of being on this very august group of people whom you've chosen to be part of these frontiers. It is a real privilege to be able to talk, to see you all, and to be part of a group of people who are very interested in being at the forefront of medical research, medical understanding. I live in Vellore in Tamil Nadu, and I work in a village in Kerala. Now, I've wanted to speak about this because of two very, very varied kind of response to this pandemic that I saw. Where I live in Tamil Nadu, everybody is very blasé, rather relaxed about the whole thing. People who help us my mother is 90 years old, so I have a group of people who come from the village to take care of her. So during the lockdown, I used to go and pick them up from the village. Now, in the village, there is not even a realization that something terrible is happening. There are no masks. There is no understanding of what is happening. So if community transmission happens, it's going to be an absolute mess. I come to work here in Kerala, and then I find so worried, so concerned. Don't even come near me. So there is a anxiety, tremendous worry about this pandemic, about the virus. So I thought it's to try and understand what is the way forward. And that's why I chose this topic along with Dr. Mahalakshmi, who guided me. How do we live with COVID-19? How do we explore and understand the COVID disease, the epidemiology, the virus itself? And thereby, when we have a clearer understanding, we are likely to respond better. Dr. Mahalakshmi, would you put up the slides for me, please? Or are you going to ask the questions first? Dr. Mahalakshmi, are you putting up the questions? Are you doing the poll now?
Sorry. Hello. Yeah. Hello.
Hello.
Dr. Mahalakshmi.
Dr. Mahalakshmi, what is happening?
I'm sorry, actually, I'm sorry. My mic was muted. Right.
Have you asked the question? The poll is over.
Going on.
Okay.
1 second. 1 second, sir. Sorry that my mic was off. I would go to Safari.
You're doing the poll.
I'm doing the poll, sir. Oh,
Sure.
so this is what is the thing. .com. The code is 504637. So the expectations from the session. People want to know recent trends, new things, how to live with COVID, exploring new fields, enthusiasm, remove fear, and breed positivity. Okay, I'll go to the next one. We wanted to evaluate India's responses and action during the COVID pandemic, especially with regard to disease containment, educating the public, preparing the healthcare system, and manage the economic impact. So this is actually a 2x2 matrix. It is looking at the efforts of the country from low to high with impact on these areas from low to high. Disease containment, we seems to be doing high effort and high impact. That's what these three people have told. Educating the public, we are somewhere borderline between high and low impact, but high effort. Preparing the healthcare system is again the same thing. We are here. That is, our efforts are reasonably high and impact is also reasonably okay. Managing the economic impact, we seem to be doing quite poorly. We are low in both. Right? That's how this 2x2 matrix works. Right? Request people to put in their polls. And the last question is about what features of Indian response do we appreciate most? So we listed features and we gave them, this is called as the $100 spend. That is, if you are given 100 points, where do you park your points on? Most of them say that promoting innovations and reducing complexity. About 11% they say that it is reducing total cost of treatment and ability to harness and handle data. 9% of them say manage uncertainty and reduce time for community spread. And 7% say media coverage and health education and behavior modification. 6% feel it is scalable, and again economic impact comes low. So this is what it is. Our audience today, majority are feeling they have a clear understanding of the topic. Their idea, topic or agenda seems to meet with their expectations on a 3.4. And some of them have attended some sessions on this particular topic. Right? And coming to the next one, the expectations from this session. So predominantly they want you to remove the fear of COVID from their mind. Help them to some strategies for management, mental health issues, new things, understand community head, and with regard to India's, can you please mute yourselves? Yeah. For disease containment, high effort, high impact. Educating the public, moderate efforts, moderate impact. Preparing healthcare systems, efforts are high, little bit, impact is low, and managing economic impact, it is on the other side. So this is the response during the pandemic and action taken. And the features of which they like best are the reduced total cost of treatment and reducing the community spread. So these are the slides for you, sir. I would stop sharing now. We can come back to this and look at it later. Thank you, sir.
Yes, surely. Thank you. Thank you. So if you can share the slides.
Sir, I have passed on the privileges to you, so you will be able to share slides now.
Thank you. Thank you. So as many of you have said, I think it's important for us to remember that we are nowhere near the end of this epidemic, this pandemic. This is going to be with us for a while. The ICMR has recently said that the peak is likely to be in November. It could even be December, which means we are looking at least at 8 to 10 months of having to live with the virus. So I think a clearer understanding of the virus, a clearer understanding of how things progress, a better clarity on the host response and the environment, the epidemiology, will help us respond better. So therefore, we're going to talk about living with COVID-19, and it's an exploration on the virology and the epidemiology of the disease. Dr. Mahalakshmi, can you see the slides well as I speak?
No, sir, slides are not on. Blank screen only is in, a black color screen.
Sorry, yes.
Yes, sir.
Is it now
showing?
Is it
no,
showing?
It's showing your my face. It is not showing the video, the PowerPoint. You'll have to click the PowerPoint, sir. Microsoft PowerPoint. Yeah.
Is it okay now? Is it all right?
Sir. Yeah, it is all right, sir. Please go ahead.
Okay, just once again, just to say that we're just going to talk about how we can live with the virus and how do we explore the epidemiology. So just to bring in a little hope right at the beginning, can I just tell you two things which you already know, but I just wanted to put it in perspective. You know, when you go to play cricket against Australia, we try and look at the weaknesses of Steve Smith and Warner, the two best batsmen they have. So, or when you go to war, we try and identify the weaknesses in the Chinese armory. So similarly, here, as we learn to live with COVID-19, with the coronavirus, it is important for us to try and look at its weaknesses as well. There are two major weaknesses. One is the fact that this virus does not fly in the air. It is not able to float around in the air on its own. And therefore, you know, if we can prevent the spread with strategies, it is possible. The second is that it can't live without us. So the virus, this COVID-19, needs us to support it, to move from one person to the other. Two simple thoughts, but two very important facts that is going to make a big difference in our approach to living with the virus to be able to contain the problem. So when you look at what happened, we know the timeline. When you look at the beginning, China alerts WHO on December the 31st after the first patient developed symptoms of in Wuhan on the 8th of December. Please watch the slide. And then on January 1st, Wuhan's wholesale seafood market was shut down. And on January 7th, the identification of the new virus COVID-19 was announced. The first death in China was recorded on the 11th of January. And the first case outside China was reported in Thailand on the 13th of January. Now, Wuhan was placed under quarantine on January the 23rd. And by January the 29th, the death toll climbs to a large number with 6,000 new cases being reported, and things started getting very bad. So when you look at the timeline as we come closer, the International Committee on Taxonomy of Viruses, ICTV, named this novel coronavirus SARS-CoV-2 and the disease as COVID-19, coronavirus infection or the disease 19. March 11th, 2020 was when SARS-CoV-2 infection was declared as a pandemic by the World Health Organization. And by the 2nd of April, the number of cases reaches 1 million around the world. And by April 10th, 2020, we had 100,000 deaths due to COVID-19. I'm sure you know this, seen this picture, you know about the transmission of the SARS-CoV-2, which is genomically similar to the other SARS, and the primary host is thought to be the bat, and either through consuming a food, whatever, it mutates, maybe use an intermediary host, pangolin, and then comes into the human host, and from there on, this mutated virus gets transmitted all around China, in those parts of China, to different parts of the world. These coronaviruses are described as alpha, beta, delta, and gamma. But the ones we are interested in, the ones that we've been involved with in the recent past, are the SARS-CoV, the MERS-CoV, and the SARS-CoV-2, the novel coronavirus. If you look at the picture, you see the envelope protein, the nucleocapsid protein, the hemagglutinin, the membrane protein, but the one you want to look at is on our left, the spike protein. That's the one that attaches itself and helps and finds a way to get into the human cell. If you follow this picture, you will find the SARS-CoV. It binds to the ACE2 receptor. I hope you're following me on that picture there. I don't have a pointer, I'm sorry. But it enters the human cell and then, like viruses do, finds a way to replicate. So there is the RNA replication, there's a transcription, and then it assembles again, and then forms a cell, forms a new virus, which goes out, and replication occurs, and then the number of viruses increase, the infection rate increases. And so what we have been able to do through trial and error is to try and find ways to contain the infection, to prevent infection if possible. So that's where convalescent plasma, the monoclonal antibodies, the remdesivir as a drug, chloroquine was tried. Various attempts have been made to try and see if we can prevent the infection. If the infection comes in, can we make sure that the disease does not become too severe? So what we have here is a picture that shows you that the ACE2 receptors are there in different parts of the body, the nose, the lung, the ileum, the heart, the eye, the liver, the urinary bladder, the kidney, the pancreas, the brain, prostate, and the testes, the placenta. So there are these receptors in different parts of the body. And that could lead to the symptoms that the patients come up with because the virus gets into these areas. I just want to show you an epidemiological comparison of respiratory viral infections, the ones that you know, the flu, for example. So the influenza virus causes, it's a pathogen, causes the influenza. And what you can see is here, the R0, or the basic reproductive number, is 1.3 only. And the case fatality rate is also, as we know, very low. Hospitalization rate is also low. But the community attack rate is reasonably high, 10 to 20%. But if you look at SARS, for example, the basic reproductive number is 3. The case fatality rate is high, about 10 to 11%. And then in most cases, you'll need hospitalization. The community attack rate is also very high, 10 to 60%. MERS was also bad. The case fatality rate is over 30%. And though the basic reproductive number, the R naught, is not very high. And let's come to this virus we are talking about, the novel coronavirus of COVID-19, the SARS-CoV-2. The R naught, or the possibility of spread to the number of individuals, is 2 to 2.5%. The case fatality rate is only 3.4%. But because of the way we are responding, the hospitalization rate at the moment is high, 19%. But the community attack rate, the spread, is 30 to 40%. This gives you a fair comparison of respiratory viral infections epidemiology as we see it today. I just want to tell you the story of one of our friends, a doctor, who contracted the infection, and her husband writes to us, and I'm sure some of you have seen his notes. He talks about the first 5 days of the infection, where she had fever, some days very high fever, and he noticed that the CRP level was slightly elevated. And that was the time when they treated her with HCQs, ivermectin, vitamin C, and zinc. On day 6, the RT-PCR turned positive. There was leukopenia. The LDH and the D-dimer levels were slightly on the higher side. She was treated with methylprednisolone and low-dose Clexane. 6th to 10th days, there was no fever. She did not have fever. But the CT showed minimal lung changes. By day 12, she began to become unwell again. The CRP levels were raised, there were moderate changes and the characteristic ground glassing on CT, and the saturation levels dropped to 90%. At that point, she was given oxygen. She was advised proning, or the prone position, and she was started on injection remdesivir. Days 13 to 16, we had a further increase. The cytokine storm was beginning, and the sugars became elevated, and she was given high flow oxygen and injection tocilizumab. After 10 days of admission, by about the 16th day, they considered intubation, but the patient refused, and she managed to remain in the prone position for quite a long time. Gradually, she improved. After 10 days of admission, oxygenation improved. There was improvement in the clinical and radiological status, and today she's back home doing extremely well. Why did some of these things happen? If you look at the slide with me, you can see the virus, the receptor, the ACE2 receptor, and there is an excessive immune response, which is what we call the cytokine storm. And there are local and systemic inflammatory responses, either in the form of hypercoagulability or in the form of endothelial damage, maybe both. And consequent to this, there's hypoxia, and there could be macrothrombosis or microthrombosis, resulting in either ARDS or pulmonary embolism. So let's look at the timeline of COVID as we see it in majority of patients. Up to day 5, there are no symptoms. By about the 5th, 6th day, there is the onset of symptoms. By day 7, the IgM becomes positive. By day 14, IgG becomes positive. And days 1 to 28, the SARS-CoV-2 RNA and antigens will be positive. By day 21, IgM disappears. Day 28, SARS-CoV-2 RNA and antigens disappear. So day 0 to 5 is what we call the asymptomatic phase. Or day 0 to 7, you could call it the window phase, where only PCR is positive. And then 14 to 21 would be the decline phase, where you may still be infected. By day 21 to 28 would be convalescence. The PCR may be positive, but you are not infective. So looking at patients worldwide, if you look at the severe acute respiratory coronavirus syndrome itself, there are over 9 million or nearly 10 million patients, confirmed cases, and nearly 500,000 deaths. So when you look at the case fatality rate of the ongoing COVID-19 pandemic, so you will find where we are in India, somewhere between 3 to 4% would be the case fatality rate. Next slide. And the total confirmed COVID-19 deaths versus cases, deaths, India ranked number 8, and the cases we are number 4, which means overall we are doing quite well. And then this is a comparison of the age groups with the case fatality, and you'll find that it is in the older age groups that the fatality is much higher. What are some of the underlying conditions, the comorbidities we need to watch out for? Hypertension, chronic lung disease, obesity, diabetes, and cardiovascular disease. And we've seen that people with these problems are the ones that develop more symptoms and are likely to succumb to the infection. So as of today, as of yesterday, as of today, if you look at the patient numbers, the SARS-CoV-2 total confirmed cases, we are nearly approaching 5 lakh, 4 lakhs 90,000, and we have 15,301 deaths. Now, this picture you would have seen, and it's good to follow this just to give you a picture about the confirmed cases versus the active cases. And one of the good things for us in India is that the number of recovered patients, the cured patients, is pretty good. And of course, it varies from state to state, from region to region. And as we've all known, as a country, we can be even seen as many countries. So the recovery rates will be different. The epidemiology will be very different. And even if somebody talks about community transmission, it may be present in some areas, but it may not be there in some other areas. And we need to keep this in mind when we talk about this. The testing updates, total samples tested till the 24th of June would about 75 lakhs. We could have or should have tested much more to be able to give ourselves a better understanding of the disease. I just want to quickly look with you at 2 countries where they had the way they responded, and the results were different. And that could help us in the way we move forward in our country. The first is a big success story in South Korea. What did they do? They had an exceptional testing strategy with kiosks, which we are now copying in India, drive-in testing. 1 in every 85 people in South Korea got tested. They had excellent, very well-planned quarantine facilities. So the sick people were admitted in hospitals. The positive people who are not sick, there were good quarantine facilities. They made sure that it didn't spread out too much. And they had a healthcare system which was very well prepared to meet any eventuality, adequate personal protective equipment, and there were masks and whatever else the healthcare personnel needed. All that was readily available. And I think the major achievement for South Korea was their contact tracing. And just to explain this to you, when the second group of people, they had come down from Italy, 3 in a family had come to Kerala. The contact tracing that I saw the government doing was amazing. They had to identify nearly 1,800 people, because by the time it became known that these 3 people were infected, they had visited several places. So every contact was identified, traced, and quarantined. And that is one of the reasons for the big success in the Kerala story. They also had a very effective lockdown. They had a separate lockdown for sick patients versus another approach for the society in terms of lockdown. At the same time, let's look at the United States. Total chaos and confusion. In the testing strategy, 1 in 630 people were only tested, 7.5 times lower than that of South Korea. And when people became ill, there was a shortage of beds, shortage of personal protective equipment, shortage of drugs. Somehow, this great country was not able to respond adequately to the needs, to the challenges that the COVID-19 infection, the pandemic brought up. And sometimes I feel that they are more indisciplined than we are. A few states announced lockdown with minimum enforcement. Most of that was voluntary. The response from the people was inadequate. So when we look at the stages of COVID infection as an epidemic, you could classify that as stage 1, 2, 3, and 4. Stage 1 is when the cases began to come into India. And it surprises me that, that here is an infection, we had nothing to do with it. It came from abroad. And when I see all those migrants walking kilometers and miles to get to their homes, I feel so bad that it was none of their fault, but unfortunately they got caught in this whole confusion. So stage 1 is imported cases. Stage 2, and that's where I believe India is in most areas, except of course a few areas, we are still in the phase of local transmission where we can still have lockdowns, regional areas, hotspots, and that's what we are trying to do. Stage 3, which I think some places in India have gone into, is the community transmission. And of course, stage 4 is the epidemic where we've lost all control over all that is happening. Just to talk to you about community transmission, the R naught for this infection is about between 2.5, maybe 2 to 3. So each one of us is likely to infect 3 people. And it is to prevent this that we use masks. How do the masks help? Because it's not, as I said, the spread is not through the air. It is through droplets. And so if in case I'm infected and I wear a mask, it's very less likely that I will send these little bits of saliva close to you. And you have a mask as well. So the droplets do not reach you. And that's where the masks become extremely important. Hand washing becomes important because droplets can fall on surfaces and you may touch it. And then, therefore, use of sanitizers and soap solution becomes important. And the distancing that we talked about, I do not like the term social distancing because it's going to be the death of societies. I use the term physical distancing, and we've talked about 1 meter. Some people want 2 meters, about 6 feet if you can stay apart. I struggle because when I see patients, I'm so used to sitting very near to the patients and talking to them. And now to have to sit 6 feet away is really difficult for me. And I'm sure many of you, it is not easy to stay far away. But I want to just talk about physical distancing as a practice at meetings, at get-togethers, when we talk, but continue to be a part of society. Please do not practice social distancing. What is herd immunity? And we've been hearing about this from epidemiologists. Dr. Jayaprakash Mulil, one of the best epidemiologists in the world who trained in Johns Hopkins University, a close friend and colleague of mine at CMC. He was our principal. He explains this in great detail, that we need to slowly develop immunity within the community. But because people with comorbidities, those who are above 60, are more prone to developing serious infection, protect them and practice reverse quarantine, keep them indoors. Let the older people be at home indoors, while the younger people are likely to have only mild infections. So they get out where necessary to do the work. And this novel pathogen, which has been introduced into our country, because no one has immunity, it begins to spread. Now, gradually, if there is no immunity, it spreads to a state where some people develop immunity. Now, earlier I've shown you a slide which talks about IgG levels, talks about a stage where the viral load, the virulence of the virus becomes very low. And then within a few months, we hope to have the vaccine. So in India, the understanding is that when we have about 50% of our population infected and responding with a good immune response, it could be maybe 60% in the urban areas and 40% in the rural areas, but a ballpark figure would be 50%. When 50% of our people have herd immunity, then the viral spread will just stop. And we're looking forward to that time. Now, the WHO strategic preparedness and the response plan for COVID-19 has two steps. One is to slow down the transmission, and two is to prevent associated illnesses and death. So the strategic objectives are, one, to get the community, not just the governments definitely, but also the people, to mobilize everyone to be part of this response. I would call that stewardship. So we own this world. And can all of us together, along with the governments, work towards this, to control this pandemic, to prevent the spread, to ensure that it does not spread? So how control the cases and clusters and prevent it from moving through the communities? And therefore, the third big effort is for all of us together to prevent community transmission. A lot of education is required, a lot of explanation is required, lots of efforts to explain, and I guess this is one such effort from my side in a humble way. The fourth is look after patients who are unwell. Give appropriate clinical care in hospitals, clinics, at homes, and reduce the mortality. Somebody told me, there's no definite proof to this, but somebody explained to me that if you start getting the symptoms, and what are the symptoms? A little dryness of the throat, a little irritation in the throat, dry cough. If you start feeling a little breathless, you might lose your taste, smell, you might have diarrhea. Someone explained, I don't have proof for this, that the virus remains inside the nostril for 2 to 3 days, and that's the time to try and get rid of it. And the way he explained to me is, try and take inhalations, steam inhalations, drink hot water, warm water, and you might be able to wash it down. I don't have a proof for this, but I've been practicing it and it's worked so far. And the fifth and the most important would be the vaccine development. And once we have an effective vaccine, but they still say it'll only be in 2021. Once we have an effective vaccine, then we have conquered the virus. So what is the way forward for all of us? May I suggest that we, having understood what it is all about, we try our best to educate others, to explain to others the use of masks, the need for washing hands, the use that try our best to have hygienic ways to live. So physical distancing. And in so doing, those who become symptomatic, take care of them really well. And I'm sure as the infection, most of it, as I said, 85% will be asymptomatic. As we move forward, we will reach that 50% infection in the country. And that will be the end of this terrible saga. Along with that, it is important to build up societies, to care for one another, to support one another. There are some people who are very frightened. We need to encourage them, support them. So as families, as societies, as institutions, as universities, as people together, as societies, we need to work together to try and defeat this pandemic. At the same time, remember that several people, lots of institutions are going through a huge financial crisis because of this pandemic. We need to look at ways of supporting them so that when this is all over, we can start life again, live together happily ever after. Thank you all for listening to me so patiently.
Yeah. Thank you very much, sir. Please accept our congratulations on very well delivered talk. I have quite a few questions which have come in the chat box, as well as people have sent the questions beforehand itself. So I'm going to take one after the other, and I would request all the participants to put the questions in the chat box so that we can take it up with Dr. Chandy. So first and foremost is from Ms. Ananya, who is an anesthesia technology student. She is asking how effective are really masks against corona? And what sort of mask?
Can you remove the slides from there? Can you do that? Oh, okay, good.
I can do that. It's not an issue. I'll do that.
Yeah. Thank you for that question. I'll just explain this again. The weakness of this virus is that it cannot float in the air on its own. Its strength is that it can remain embedded in the droplets. And studies have shown that even as we speak, and some of us speak softly, some of us speak rather loud, some of us shout, as we speak, the droplets go far away from us. So even 3 feet, 4 feet, actually you can practice that and see. When we speak, we'll find that unknowingly droplets go to maybe 1, 2, 3 feet. The mask is, first of all, to prevent that from falling. It'll get caught within the mask. And the person I'm speaking to wears a mask so that by chance, if I sneeze or something, that person is also protected. So basically, it is to hold the droplets from going at somebody. So if you don't have a mask, and let's say you are in an elevator, let's say you're traveling in a bus, somebody sneezes, somebody coughs, it's very likely that the virus in the droplet particle will enter you and you'll get infected.
Okay, thank you, sir. I have next question that is from Dr. Niranjan, Dr. Arun Daniel, one Dr. Satish Babu, and Ms. Shabnam. They're all asking about herd. The first
Yes.
question is, what percentage of the population has to develop herd immunity before we move forward? The second question is the herd immunity which is developed through community transmission different from the herd immunity which can be induced through vaccines? I think it's taking polio as example. And there is one question from Dr. Arun Daniel, which I found it was very pertinent. He says that this particular virus keeps mutating and there is not a single stable strain. So in this case, do you think that herd immunity is going to matter much? So that is one thing. And is this the time to talk about herd immunity and open up the lockdown? Right. So that is one more question which has come from that. And I think these are the three questions or four
Yes.
questions which came related to herd immunity.
Yeah, thank you, Dr. Malakshmi. Very good questions. Arun, I was also quite worried about this, about the mutation, because I am a hepatologist. I deal with hepatitis C virus, and I know how it tends to change a lot. So this is something I was worried about. But what we have today from experts is the message that it does not mutate as much as we thought. So the vaccine they are looking for is against a stable virus. Now we don't know whether, like the influenza virus, every year we will have something new coming. But at the moment, what they are working on is a vaccine towards a particular fairly stable strain. That's my first answer. Whether it will start mutating, at the moment, this is where we are. I hope it doesn't mutate. About herd immunity, what happens is that, again, I'll try to use the example of hepatitis A. Hepatitis A, I'm sure all of you, many of you young people have never had it. My generation, everybody had an episode of infection of hepatitis A. What happens there is it spreads through water, it spreads through food, through flies, fomites. So when you are a child and you get an infection of hepatitis A, you don't even know it. It might just be one day of feeling a little unwell, little nausea, fever, and you get lifelong immunity. While if you get it when you're old, the jaundice and all the problems that come with it, the morbidity is very, very great. If it is the same with COVID-19, and to my understanding so far from what we see, it seems like that. At least what we have in India, the strain seems to be relatively mild. Is it because it's period of time by the time it came to India? We don't have clear answers. But if you look at the way what has been happening in India, the morbidity, the mortality is less than, let us say, Italy, for example. And so could it be because our immunity is better, because we've had so many infections and we have so much of bacteria in our intestines? Again, not clear, but these are areas that we can look at. So when somebody gets infected, and with the R naught of 2 to 3, you will have people getting infected. And if these people who get infected are young people, people below the age of 60, people who do not have any comorbidities, hypertension, heart disease, diabetes, those who do not have any reason to have a low immune response, they will, they'll probably have asymptomatic disease, and then they will develop an immunity. And as it spreads in that fashion, by the time we get about 50% of our people who have had the infection, and the epidemiologists say that probably it will be 40% and 60% when you look at the rural and urban areas. So on an average, 50%, that will be the time when it does not spread anymore. That is what we would describe as herd immunity.
Okay. Thank you, sir. That was very simple and very nicely explained. And there are a few questions with regard to vaccine development, taking from the herd immunity, what we have been discussing. Dr. Gopinath, he is asking what exactly are the hurdles in the making of the vaccine? Are we likely to get anything in the near future? And will it help us to combat the pandemic?
Dr. Gopinath, as you know very well, what happens in trying to develop a vaccine, one is to make sure that the vaccine does not cause any harm, and I'm sure they're working on that a lot. They will look at trying to see, is there a way in which you can improve or increase the immune response in the host, in the person who is given the vaccine, for which they will either use a strategy of getting us antibodies in whatever form, either in plasma or it could be something that is created, or they could use attenuated or killed viruses. This is the way in which vaccines are developed. Once the vaccine is developed, they'll have to go for animal trials first, and then they'll have to look at human trials. And unless though there have been 1 or 2 reports of vaccines being available, it certainly can't be accepted because if the vaccine has to be effective, useful, it has to be cheap enough, good enough, available enough for a large group of people all over the world. And this is a pandemic. It's not as if like what you have in polio, that you can go to certain areas and try to contain it. Our country managed it. But it is very, very important that the vaccine is safe and the vaccine is effective for the vast majority of people. And again, another very important point is, how long does this vaccine last? Now, one of the worries with this infection is that now people are saying if you've had the infection for 2 months, definitely you have adequate immune IgG in your antibodies in your bloodstream. But that's not enough. You want a vaccine that will last a long time so that the infection is prevented.
Very much, sir. I have a question. I read this book by Thomas Abraham, who actually was talking about what lessons we have learned from SARS epidemic and how it has helped us to kind of do this. So, and you explained very nicely in your slide the infectivity or not and the incubation for all these things. So, can you tell us like what lessons we can take forward from what we have learned so far and how we can manage our strategies in the future, apart from physical distancing and personal protective equipment and other things? What other things should we be doing as a healthcare system?
I think one of the very important things, as I see it, is information sharing. And information shared without, we don't want the kind of thing that happens sometimes in the media. It's not to frighten people, to try and give the correct information. Unfortunately, there are so many myths that are going around that it has really frightened the people. So the first thing I would do, Dr. Mahalakshmi, to respond is, if it is possible, can we give the correct information in the correct way, in the correct quantity, so that people are not only able to understand, but also respond effectively. Secondly, I would move into the community and use the community health departments to go all over our country to give information, explaining to them. At the moment, there's a huge fear factor which destroys everything. There's no need for us to get so frightened. So if we have a clearer understanding of what this is all about, and they've at the same time explaining to people what the methods of prevention are, and also explaining that if you get symptomatic, these are all the things to do. If we have areas where we can take care of them, I think we should, as a country, be able to do well. But unfortunately, we've not succeeded in these 3 areas.
Thank you. he said, common sense is always short in supply, right? And
Yes.
I think we have quite a few questions, sir. So what I would tell all the participants is that we would share these questions to you and also the participants' contact details. So if it is possible, we can take this discussion forward and keep it going. But before we conclude, I have a very nice question which has come from one is Dr. Rohit Goyal from MAMC, and also paraphrased a little differently by Dr. Satish Babu from JIPMER. See, the thing is, during this COVID pandemic, we have seen that lot of outrage, especially from the public, when dead bodies for of patients positive are being brought in or brought for cremation and all, which is causing a lot of heartburn among people. So this is, how do we deal with this angry, grieving, fearful public and relatives? That is one question which Dr. Rohit has asked. And what Dr. Satish Babu has asked is very nice. So in this time, how can humanity be taught and into students, and what lessons we can take from this pandemic for the future healthcare providers so that they shape up in a much better fashion? So I think that.
Thank you, Dr. Mahalakshmi. Rohit, I fully empathize with you and the concerns that that you have, because this has been my greatest worry, and that is why I said we must get rid of this term social distancing, because people were getting very happy with staying far away. You know, even on an elevator, you are expected to turn towards away from people. So somehow we are being taught to stay away from one another, but to be frightened of one another. As it is, you can't see anybody's face now. You can't see whether the person is angry with you or the person is smiling. And then you are expected to stay far away. Good to see Dr. Mahalakshmi's face. I don't see many faces, Dr. Mahalakshmi, so it's great to see you and to see you smiling. So there is so much of fear, so much of misunderstanding. So I think it is important for some of us to go on an overdrive to try and tell people the truth. The fact that we don't need to be so frightened. Actually, nobody has really put out figures about how infective a dead body is. It is really not that infective. But somehow there is so much misunderstanding. First of all, now if you're burying a person, you have to do it not 6 feet, you have to go 12 feet. And then, you see these pictures of people just really, really scared. So I feel that some of you who obviously are socially conscious, some of us have to come out and really go on a campaign to try and help our society to stay together, to continue to love and be with each other. The other terrible thing is my medical students, the parents are saying, please don't go anywhere near any patient. Any history that is taken from about 12 feet away. How can you take a history of a patient and these are not even COVID patients. This is with a preventive effort. They stay so far away. Where are we going as a community? So I think in a way, this is God's way of showing us a way to come together, closer together, to build up communities and societies. Thank you for that question.
Yeah, thank you very much, sir. I think by the way you have answered, you have actually cleared Dr. Lakshmi Kanta, Professor of Anatomy from Wayanad, right? And this is what she had quite a bit of concern. How are we going to maintain our health, mental and social well-being in the current pandemic, and how to prevent these similar situations in the future? So that is what Lakshmi Madam was very much worried.
I'll tell Dr. Lakshmi one story that happened here in our hospital. Suddenly we saw during a period of 10 days, we had 5 patients who came with intestinal obstruction. And finally, we had 16 such patients. And these were all patients above the age of 60, patients who've had surgery before, who were in lockdown, no exercise at all, and had taken a lot of jackfruit. We are in Kerala, so we've taken a lot of jackfruit, and some others had taken mangoes. So the fiber, because of the previous surgeries, had resulted in intestinal obstruction. Fortunately, 15 of those 16 patients we were able to manage conservatively. And I worry for those who've become extremely obese during this time. I worry for those whose lifestyle has changed because of this. You know, there are several homes where the windows are closed, the doors are closed, they don't come out of their homes. And I hope it won't, that people will begin to understand that we need to live, that we need to come out of our homes, walk around. And in fact, the advice is that let us use less of air conditioning. Let's have our windows and doors open so that the air can move freely. So I really hope that we won't have more and more problems because of the lockdown and the problems of the virus.
Yeah. Thank you for taking that up and making it clear. And if you remember the first initial slides, what we got, what is the greatest expectations from this particular talk? The biggest thing in the word cloud was, I want that fear factor to go. So I hope this, by making it extremely clear and very lucid presentation, that fear factor has been taken away. And also like the way in which you have explained how as a community we need to come together to ensure that an appropriate response is created. And we also need to contribute so that the future of medicine, that is our students, also understand the importance of these issues and display professionalism during this thing. Thank you very much for a very nice and excellent presentation, sir. Shall I say as usual, because I've heard you now quite a few times now. Thank you very much. And on behalf of the Scientific Society of AVMC, Aarupadai Veedu Medical College, and also the Vinayaka Mission Research Foundation, and all the participants, I thank you for this excellent lecture. And friends.
Thank you, Dr. Mahalakshmi. Thank you, Dr. Kotur. Thank you, participants. It's a privilege.
Yeah. And friends, as usual, we will have another interesting episode that will be on the next week, that is on the 3rd of July. We are going to continue to explore this COVID pandemic and how it is. As you know that one of the states which had the maximum number of COVID cases in the country was Madhya Pradesh. So we have with us Dr. Shashank, who is an additional professor of microbiology from the AIIMS Institute, Bhopal. So he would be discussing what strategies as an institute they took to prevent the spread and to contain the disease in their response to this pandemic. So that is the talk next in the line for you. And I would like to remind all the participants that this session has been recorded. We will share the link for YouTube and Facebook recording to you along with the feedback form. You would get a SMS. What is the link to give the feedback? And once you give the feedback, you can download the certificates. So that is the thing. And with a promise to Dr. Chandy that we will be sharing all the questions to him. And if any such things, sir, can continue the discussions with the participants. So thank you very much, folks. We will see you again next week on Friday, afternoon 2:45. And thank you for this excellent session. This is Dr. Mahalakshmi, Dean, Health Professions Education from Aarupadai Veedu Medical College. On behalf of the Scientific Society, signing off. Good day. Bye-bye.
Thank you, Professor Chandy. Thank you.
Thank you, Dr. Kotur. It's a pleasure to be here with you.